So good morning again, this is Cardiovascular Hemodynamics. So very briefly, some of our learning objectives for this presentation are to comprehend the basic hemodynamic concepts of the cardiothoracic system, discuss the normal values of hemodynamics, discuss methods of monitoring perfusion in terms of anaerobic and aerobic metabolism, understand the difference between oxygenation and ventilation, examine the cardiac system, and to learn the alterations of traditional hemodynamics when mechanical circulatory devices are in place.
Really light stuff. Honestly, this is just basics. We're going to start off the morning really simple things that we should know, ought to know, will know, hopefully learn something. My name is Hannah. I've been a nurse for about 17 years. Currently, I'm in the CV ICU here at Methodist. I am a bedside nurse and also an ECMO specialist.
And my name's Jenna Kohout. I am a nurse as well in the CV. I'm our RN4. I've been a nurse for almost actually over 10 years. I've spent the last 3 here at Methodist in CV. I do a mix of bedside and education for our staff. Okay, so first things first, can anyone tell us the normal flow of the heart? You can shout it out.
Blood flows through the heart.
Where do we start? SVC to RA through what? Okay.
Pop quiz.
Sure. Just kidding. I think collectively we're close, yes. So again, just as a refresh, we're coming in through the superior vena cava, into the right atrium, through the tricuspid valve, into the right ventricle, through the pulmonic valve, into the PA. You get oxygenated in your lungs there, comes back into your left atrium, into your left ventricle, through your aortic valve and out the aorta. So I know it seems kind of basic, but it's always good to refresh and just have a visualization of this. So as we move forward and we're talking about the different parts of hemodynamics, you can kind of see where we're at. Another way, if you're more of a visual learner like myself, to look at hemodynamics, here's basically a chart that we will be referencing throughout the presentation as well, split between lungs and the heart. So first we'll start with the lungs. So our cardiopulmonary physiology. So our pulmonary system, what's the goal? It's to deliver oxygen to the bloodstream and to remove excess carbon dioxide from the body. Your cardiovascular system role is to supply oxygen-rich blood to the organs in your coronary arteries. And the purpose of our heart is to pump blood through the vascular system and basically deliver that oxygenated blood to the tissues to meet the metabolic demands of the body. Okay. Ventilation versus oxygenation. So ventilation is the movement of air in and out of the lungs, physical active breathing. It's going to remove the CO2 and supply the oxygenated blood to the alveoli. How do we measure this? By our PCO2, our tidal volume, and our respiratory rate, all of which factor into your minute ventilation. And then it's going to be affected by airway resistance, lung compliance, and respiratory muscle function. Whereas oxygenation is the process of getting oxygen from the alveoli into the bloodstream. So delivery of oxygen into the tissue and cells for the cellular metabolism and energy production. We measure our oxygenation by our PaO2 and our SpO2, and it would be affected by things like hemoglobin and infection, like pneumonia and edema and ARDS.
Okay. Some commonly monitored hemodynamic parameters. So basic stuff that we see all the time on our monitors, blood pressure, the MAP, as measured by the MAP, blood flow, like your stroke volume, and systemic vascular resistance. Vascular volumes is measured by your CVP, your heart rate, your ventricular function, so your ejection fraction, cardiac output, cardiac index, and then your oxygenation, your PaO2, SvO2, and your SpO2. So just a little caveat, your SpO2 is a late stage indicator of poor oxygenation, and so it can be affected by fake nails, edema, and it can have inaccurate readings. All right, why do we monitor hemodynamics? So basics, really, like we monitor cardiac function, assess tissue perfusion. It guides our fluid and medication therapies like fluid resuscitation. It evaluates the effectiveness of those interventions, and then it can predict and detect deterioration early, and it can diagnose and manage shock. All right, a little back to our image here, if that helps. So perfusion is the passage of fluid through the circulatory system to an organ or a tissue. It's the delivery of oxygen-enriched blood through the capillary beds, and it's measured by your MAP, your SvO2, lactic acid, and patient assessment. So what is your MAP? Your MAP is your mean arterial pressure. It's the pressure. MAP is the perfusion pressure that drives blood to the body's organs. Typically, it's about 60 to 80. We like to think the minimum is 60 to perfuse all your organs, 60-ish. MAP is measured by your systolic blood pressure plus your diastolic blood pressure times 2 divided by 3. So if you don't have an Edwards or a hemosphere or something, you can still measure your MAP manually. SvO2, mixed venous oxygen saturation. It's the amount of oxygenated blood returning to the right side of the heart after the tissues remove what they need. So it's measured in your pulmonary artery drawn from a PA catheter. You can also get it from a central line. It's going to be your ScVO2, and it'll be more accurate if you get it from a central line like the superior vena cava versus it's not going to be accurate if you get something that's in your inferior vena cava. And then you just have to keep in mind your values are going to be a little different. So an SvO2 is 60 to 80. So an ScVO2, if you draw it from a central line, it'll be more 70 to 85. Factors affecting your SvO2. So this is really simple. I can get into the weeds on this, but mainly your causes of high SvO2 is when your oxygen supply exceeds demand or extraction is impaired. So think if you're mechanically ventilated and your FiO2 is 100%, you may not necessarily need that 100%, so your SvO2 will read high. Low SvO2 is your oxygen demand exceeds your supply. So think the easiest way to think of that is if you're bleeding or you're anemic. Your demand is going to exceed the supply. Okay, lactic acid. What is lactic acid? It's a measure of indirect tissue perfusion, and it occurs during anaerobic metabolism. It can be caused by strenuous exercise, hypoxia, sepsis, acute cardiac event, liver failure. There is a difference between type A and type B. That's getting into the weeds, but type A is it's basically due to conditions due to inadequate oxygenation. So anemia, again, respiratory failure, shock. Type B is any other factors such as medication, toxins. Those can cause lactic acidosis as well. Really quickly, so we've talked about numbers, but when you're stepping into your patient's room in the morning and you look at your patient, you're doing your patient assessments, what are some ways that you can assess perfusion just by good old-fashioned patient assessment? That's a question to y'all.
I heard pulses, yeah. Skin, temperature, yep.
Right. So your pulses, your skin color, temperature, are they mottled? Are they cool, warm? Urine output as well, low urine output. Mental status, that's a big one, altered mental status. So just basically, so if you didn't have any of these numbers, if you didn't have a quantifiable way of knowing your perfusion, then there are the simple things that we do every day by just putting eyes to our patients.
Okay, now we're on the second portion of the heart. So now we're looking at cardiac output, which is made up of your heart rate and your stroke volume. Sorry. Okay, so again, cardiac output, it's the volume of blood pumped by the heart and measured in liters per minute. It's calculated by your heart rate times your stroke volume. Normal is 4 to 8 liters per minute. But I know here in CV and probably where y'all work as well, We really watch our index more specifically. It takes in account the patient's body surface area, makes it a little bit more patient-specific, if you will. So when we're looking at things that will affect your cardiac output, we look at our heart rate, right? So maybe you think high heart rate, we should have a higher output. However, a high heart rate decreases that diastolic filling time. If you have less filling time, you're going to actually decrease your stroke volume. Your output could plateau or probably drop due to your faster heart rate. As well as atrial fibrillation, when you have that loss of atrial kick and you have an irregular ventricular response, you're actually going to decrease that overall cardiac output as well. And then with a low heart rate, you're also going to see a decrease in your output because your heart's just not beating often enough to maintain that adequate perfusion. So then we look at stroke volume, and it's broken into 3 categories, right? Preload, which is your volume, afterload, which is your resistance, and contractility, which is the actual contraction of the muscle fibers. Back again to my chart for preload here. So what is preload? It's the volume of blood that's returning to your heart or your venous return. It's also the amount of stretch that's experienced by the ventricular muscle cells or myocytes at the end of diastole, which is the relaxation and filling phase. So clinically, we measure this by the CVP and then also by patient assessment, right? Lung sounds, JVD, edema. Things that will affect your preload would, quite frankly, be your total blood volume. So the amount of blood that's returning into your right atrium, your ventricular compliance, otherwise known as your ventricular stretch, and that's the ability of the ventricles to stretch and fill prior to contraction. And then atrial contraction. This should improve your ventricular filling, and as we briefly mentioned with atrial fibrillation, it actually causes a 20 to 30% decrease in your filling time when your patients are in AFib. That is why, part of the reason why we care so much about that when they are fresh post-op. So our management of preload, if we want to increase preload, seems pretty simple. We're going to give fluid, right? Whether it's lactated ringers, albumin, or blood products. If we want to decrease, our list starts most invasive, we can dialyze. Otherwise, we can try diuretics, or we can give vasodilators, nitroglycerin, nitroprusside, or milrinone. Okay, so, oops, sorry.
No, sorry, pop quiz, just preparing y'all.
Yeah, your post-op CABG patient has been in the unit for 1 hour, and here are your hemodynamics. BP 82/40, MAP is 54, your CVP is 7, heart rate is 120, pulse ox 95, and index is 1.8. What are your concerns or your next actions?
I think I heard somewhere fluids.
I didn't take into account how hard it would be to hear people back. But yes, fluids. Yes, we have a very low blood pressure, low CVP, high heart rate to compensate, which we know will not increase our cardiac output. So this person, they need fluids. Okay, so now we're looking at afterload. So what is that? It's the resistance that the ventricles must overcome to be able to eject blood during systole. When we're looking at it, again, back to our picture, we're looking at a right side versus a left side. So if we're looking at right ventricle afterload, we are looking at your pulmonary vascular resistance. This is going to reflect the changes in the arteries that supply blood to your lungs, which will affect the emptying of your right ventricle, right? So as you can see in the RV, as it's going in through the pulmonic valve into the lungs, if that is very high for whatever reason, it's going to cause that RV to stretch, thinking it can get stronger if it gets bigger, which it doesn't, and then it can actually lead to right-sided heart failure. And then on the left side here, we are measuring our afterload in our systemic vascular resistance, which reflects the changes of the diameter of the arteries that affect the emptying of that left ventricle. So vasoconstriction will increase your SVR and vasodilation will decrease it. It's also affected by the condition of your aortic valve. Things that will increase your afterload on the left side would be things like hypertension, aortic stenosis, vasoconstriction, and atherosclerosis. Again, all the narrowing. The right side of the heart is going to be pulmonary hypertension, pulmonary embolism, and pulmonary stenosis. Ways that we can decrease our afterload. So on the right side, if we need to decrease that PVR, we can give pulmonary vasodilating medications. Maybe you've seen or heard of inhaled nitric oxide. inhaled or IV prostaglandins like Remodulin or Velitree, and sildenafil. Aortic regurg is going to reduce the forward flow, which would reduce your afterload. And then vasodilation is how you would also decrease your afterload, whether that's something we do to the patient via medication like morphine, beta blockers, milrinone, or nicardipine, or if it's because of a reaction like anaphylaxis or sepsis. Okay, contractility. This is basically the measure of how well the ventricle squeezes. So we measure this with our ejection fraction, a very rough normal of 50 to 70%. I know in our unit we don't see a whole lot of EFs up to 50%, but your EF is then measured by an echocardiogram, whether that's transthoracic or transesophageal. Something that will decrease the contractility would be cardiomyopathy, hypoxia or hyperkalemia. And it would be increased by positive inotropes like dobutamine, sympathetic nervous responses like us right now, fear and anxiety, or hypercalcemia. I bet my heart's just booming. Okay. So how would we increase our contractility? We pump up the tank, right? We give ourselves a higher preload. We can give calcium or inotropes like DIG, milrinone, epi, or dobutamine. How would we decrease it? Medication-wise, right? Lidocaine, or inotropes like beta blockers, amio, calcium channel blockers, or nitroglycerin. Another pop quiz. Okay, so your patient's here again after 1 hour. It's a different patient, even though the blood pressure is the same. 82/40 with a MAP of 54. Your CVP is 16. Your heart rate is 105. Pulse ox 95, SVR 600, and index is 1.8. What should we do? Is fluid the answer? Excellent. So yeah, we need probably pressors or maybe an inotrope for some right-sided support, right? Our blood pressure is low, but our CVP is high. We need help with that squeeze. And our SVR is also very low. Oh, thank heavens.
Almost here. Device considerations. So this is just a very quick device consideration. There's a lot of things that can affect our hemodynamic monitoring. So some of those would be a balloon pump. So your intra-aortic balloon pump is a balloon in the aorta that inflates during diastole and then helps improve coronary perfusion. It decreases afterload and by assisting the left ventricular contractility. Your monitors will read normal for your cardiac output and cardiac index, but it's not going to accurately reflect your ventricular function because it's being assisted. Your VADs, so left ventricular assist devices, so this includes your durable VADs and your Impella. So it's a continuous flow, provides non-pulsatile or low pulsatile flow. So decreased pulsatility will affect your, main thing is your blood pressure. So if you, in the ICU, we're blessed to have art lines and we can see the blood pressure. However, on the acute care floors, you'll have the non-invasive, but if you have a patient with an LVAD, with no pulsatility, you're not going to be able to measure their blood pressure, so you'll have to Doppler the blood pressure. Your cardiac output, your cardiac index, your SVR are going to be unreliable using regular thermodilution monitoring. So keep that in mind when you have these patients and you're looking more for a trend. These patients will still have those monitoring devices there, but you're looking at their trend and specific to them. ECMO is a big one. I mean, ECMO basically bypasses your whole lung and heart. Depends if you have a veno-venous or veno-arterial ECMO, so it can bypass everything. Your CVP is going to be way off. It's basically 3 to 5 liters of blood that's being shunted away, like taken out of your body through a machine and then put back. So it's not going to accurately reflect your heart function. Your SVO2 is going to be off. When you're measuring SVO2, you may have to use different methods. You won't be able to use your regular like PA catheter. You may have to use the actual machine. So those are device considerations when you have an ECMO on your patient.
So really, in summary, we know how wonderful technology is for us at the bedside as nurses, right? We know how much we rely on all the numbers, but just really remembering that everything really is a trend. Assessing and treating our patients first, and then utilizing our numbers second is just really critical in any phase of care.
Any questions?
All right. Thank you guys so much.